All right. Okay. Good evening, everyone, or good afternoon, good morning, wherever they are. Welcome to another session of Inspire International Webinar. Basically, for those who don't know, and probably Aparna, you might have been aware as well. Inspire is an organization we started, I think, a couple of years ago, just before the COVID. It's an Indian organization of pediatric and neonatal intensive care. So all the doctors and nurses in Qatar, they're part of it. And we started this webinar series after the COVID, and we're getting quite good response with the audience across the world. And this is in this series. And thank you for accepting the invitation. Before delaying, we have Dr. Rupali Soni. She's one of our founder member of Inspire, but she's moved to Dubai now, and she's agreed to moderate these sessions. She's a consultant neonatologist at Parkville Mediclinic Hospital in Dubai. So she will be conducting the session and introducing Dr. Aparna. So over to you, Dr. Rupali.
Thank you. Thank you, Kiran. And hello, Dr. Aparna. It's lovely to have you here in this session today. And I have the pleasure of introducing you. And I have had the pleasure of meeting Dr. Aparna on a very lovely evening in Doha, Qatar. And she is indeed a pleasure to know. And it was lovely to spend the evening with her. So without further ado, I want to tell you a little bit about Dr. Aparna. She completed her pediatric intensive care medicine training in India, UK, and Canada. She's a consultant pediatric cardiac intensivist at Great Ormond Street Hospital. And I think there's very few people who wouldn't know about Great Ormond Street Hospital. It's a quaternary referral center for children with all sorts of congenital malformations, but also congenital heart disease, and a nationally commissioned center for ECMO, mechanical bridge to transplantation, cardiothoracic transplant, and primary pulmonary hypertension and tracheal disease. She's a honorary lecturer at the University College London and Great Ormond Street Institute of Child Health, and leads on a theme of neuromonitoring, neuroprotection, and neurodevelopmental outcome in children with heart disease and those supported on ECMO. Her research focus is to establish measures to identify neurological impairment and neurodisability before and after major cardiac surgery, to establish structured follow-up for ECLS supervisors, and to study cerebral oximetry as an early marker of brain ischemia. She has expertise in clinical governance, patient safety, and quality improvement within pediatric intensive care. She's also a member of the Pediatric Intensive Care Society UK and is on the Mechanical Circulatory Support Task Force of ESPNIC. And today we are very lucky to have her doing us a session on neuromonitoring in ICU. And as we all know as clinicians, our population of patients being babies and children are very, very vulnerable to brain injury because they have a developing brain, a constantly growing and developing brain as compared to adults on ITU whose brains have already matured. And so very, very important aspect of our care in pediatric population is neuromonitoring in ICU. And I'm sure we all wish we had a magic wand to look into their brains, to fix their brains, and to allow normal development to happen. But unfortunately, this doesn't always happen because of the pathologies that our patients come with. So without further ado, we have Dr. Aparna talking on this very important topic today. Thank you very much.
Thank you. Thank you very much, Kiran. Thank you very much, Rupali. I presume you all can see, hear me, and see my screen, yeah?
Yes.
Yes.
Okay, thank you. So it really gives me great pleasure to be talking to you all on this pet subject of mine, which is neuromonitoring in ICU. I am going to focus a little bit on critically ill children, particularly neonates, but also I'll cover a little bit of children who have had cardiac disease. and are in cardiac intensive care, and also and neonates on ECMO. So I'll try to keep it as broad as I can, but there might be some focus on cardiac and ECMO. So, okay. So I have no disclosures apart from the fact that I am part of the EuroAXO Scientific Committee, and I'm also the section chair for mechanical circulatory support and cardiac intensive care within the ESPNIC organization in Europe. Just want to start off by saying that the ICU presents us with multiple challenges, and this is a very sick little baby who has had major cardiac surgery and is, as you can see, supported on ECMO and is getting, full intensive care therapies that we can think of at the current moment in time. This baby, as you can see, is fully sedated, muscle relaxed. We're using NIRS infrared spectroscopy, the NIRS machine here you can see, to help us with some monitoring. And you can see this is the type of patient that worries us as to what is going on in the brain. And like Rupali said, we wish we had a magic window which would tell us exactly what's going on. But sadly, we don't have such a thing. And we'll explore now the different modalities that are available to us and what we can do in terms of trying to make some sense out of it. Okay, so this is our neonatal intensive care unit. I just took a picture of the neonatal ICU this morning, and you can see how, neuromonitoring in the critically ill neonate behind the closed environment of the incubator can be a furthermore challenge. And this is again something that we need to understand more and see how we can explore this further. So a few other concepts, as I said, this is a little baby with open chest, post-cardiac surgery. This is the patient who is slightly older, an infant who's open chest on cardiac ECMO. And then we have the artificial heart, which is the Berlin heart. This is a toddler who has got the Berlin heart ventricular assist device, both on the right and the left side. And this would be initially an intubated patient and then an awake patient. So you can see that neurological injury can be seen in different contexts in the intensive care unit. Now, neurological complications broadly can be classified as intracranial hemorrhage, seizures, ischemic stroke, and brain death. And they're very important because we know that they contribute to significant morbidity as well as mortality. And I'll show you some images here, and particularly I focus on CT scans. We have a 1-week-old neonate with persistent pulmonary hypertension of the newborn, severe respiratory failure, 4 days into a VA ECMO run. This child has had seizures, and you can see that there are bilateral watershed areas of infarction. This is a term neonate who's had a placental abruption, fetal distress, emergency section, again, poor APGARs, seizures, and here you see a massive hemorrhage in the brain. And this is a slightly older child with cardiac ECMO. You can see 1.5-year-old who's had a mitral valve replacement, an artificial valve. There was difficulty in anticoagulation. The patient arrested, had to go into emergency ECMO. And you can see a small little bleed, which even though the patient survived ECMO, the patient subsequently died of a massive intracranial hemorrhage. So it's really, really important for all of us to understand this, that in the intensive care unit, the children are extremely susceptible to neurological injury, and the causes of that are multiple. And say for example, if this is the congenital heart disease patient, you can see that there can be insults in the fetal life. There can be insults in the postnatal life, hypoxia, hypotension, acidosis, cardiac arrest. The heart surgery, the cardiopulmonary bypass, exposes the child to another very important risk, and that is microemboli, hypoperfusion, ischemia, reperfusion injury, hemodilution, pH management. In the intensive care unit, we know that children have swings in blood pressure, swings in oxygenation, and this and low cardiac output rate. All of this can disrupt the cerebral auto-regulation, and furthermore, they are subject to sedation management, prolonged intensive care, along with all its complications, which can further contribute to brain injury. And then there are some things which we have no control on, the genetic polymorphisms, the genetic syndromes that many children who are critically ill might have. Now, if you look at neonatal ICUs, there can be a lot of neonatal onset encephalopathies. You have the perinatally acquired hypoxic ischemic injury, the hemorrhagic or the inflammatory or the infectious brain injuries in the neonatal period, the intraventricular hemorrhage, which is of a severe grade in preterms, thromboembolic brain injury from whatever cause it may be, perinatal strokes, and finally, the neonatal and onset epileptic encephalopathies, whether it is due to structural, metabolic, or genetic etiology, all these can cause brain injury in neonates. ECMO is an extremely highly complex technical therapy, and we again know that neurological injury related to ECMO can be multifactorial, and again, there can be pre-ECMO factors, on-ECMO factors, and post-ECMO factors. You can see that, again, the causes can be primary, underlying disease, congenital syndromes, could be the pre-ECMO hypotension, acidosis, hypoxemia. Cannulation itself can cause injury. Then the reperfusion injury, that is when you connect the patient onto ECMO suddenly from a hypoxic state, they have a luxury of an hyperoxygenated state. CO2, which may be high, can suddenly go down once they're connected to the circuit, and the blood pressure can change the moment you're connected onto ECMO. So all these swings, and I'm going to talk a little bit more about these swings, these sudden changes. I think these sudden changes can be extremely important when it comes to cerebral hemodynamics. Again, once you're on ECMO, you know that there can be heparinization, which is essential, and this heparinization exposes the child to bleeding and or thrombosis. Cerebral autoregulation can be impaired on ECMO, and not to forget the cerebral venous hypertension that can happen on ECMO, especially when you have cannulated the cervical vessels. So when I think about neuromonitoring, I always think about it in the context of optimizing neurological outcomes. And it's not just important to just do neuromonitoring. I think it has to go hand in hand with neuroprotection and hand in hand with neurodevelopmental outcomes. And all these three factors will be crucial in optimizing neurological outcomes. So, however, there are some factors which are way beyond our control, but there might be some which are modifiable factors. And I think we need to identify these modifiable factors and try and work on a bedside approach to neuromonitoring and neuroprotection in the intensive care unit. So let's talk a little bit about neuromonitoring. And again, I'm showing you the intensive care unit with the multiple infusions, the ECMO circuit if need be, various other things which makes it very difficult to really assess the neurological state. And ideally, what we would like is a bedside clinical examination. That's our ideal, that's what we would want to do. But most often, it is limited because of the effects of sedation and muscle relaxation that we have to commonly use in a critically ill neonate. And I'll talk a bit about this in detail more, but this is something that we're doing more and more, where we use an ultrasound scan to give us an idea of the optical nerve sheath diameter and pupillary reaction, where sometimes it may not even be possible to look at pupillary reaction when children are very sick or when they're very edematous. Now, ideally, the most important thing is regular clinical evaluation at the bedside, and here it is so important on the role of the bedside clinical nurse and the bedside examination. So you have, avoid muscle relaxants as far as possible and minimize sedation use. Many of us these days are trying to totally avoid muscle relaxation. And even if we have to use them, we'll give a muscle relaxant holiday every day. We also try and minimize sedation use and also try and use a sedation holiday every day. And in patients who are very sick on ECMO, there is a big move to try and reduce sedation and keep them awake. And though it's not possible as much in pediatrics, but it may be possible in older adolescents, but definitely the whole world is moving towards awake ECMO management. And that is mainly because it gives you the opportunity to do clinical examination. So now looking at the neuromonitoring modalities available, I'll talk a little bit about all these things here. That is cranial ultrasound scan, optic nerve sheath diameter, CT scans, and EEG, not necessarily in this order. But I think one thing that I'd like to say here, that all this long list, none can safely, continuously, and reliably foretell what's going to happen. And that's what we would like. We would like to know what's going on, and we'd like to know if there is a potential issue, because if there is a potential issue, we want to intervene before there is a seizure, before there's an infarct, before there is a bleed. So, so really, because not one modality can help, we tend to use what we call the multimodal or combination of monitoring modalities. And again, as you can see here, there are multiple things here from NIRS, AEG, EEG itself, the optic nerve sheath diameter, transcranial Dopplers, ultrasound, CT, and of course the MRI, which is now we're doing more and more of the MRI in brains in children. So, EEG, what we would like to use, the neuromonitoring modalities that we'd like to use by and large and more commonly is EEG, the ultrasound scan, and the CT brain. And then the other ones that I'll talk about a bit in this is the NIRS, the AEG, and a little bit about the MRI. So multi-channel video. Yeah.
Yeah, I think there was a comment about the voice is softer. I think I'm able to hear you, but is there a way you're close to microphone, or there's nothing blocking of the microphone or anything, right? You're on the laptop.
I don't think so.
Okay.
I don't think so.
I think I'm able to hear it. There was a comment. That's fine. Okay, you can continue, I think. Yeah.
So I've maximized my volume.
Better now. I think now.
Better?
Okay. Yeah. Much better. I think. Yeah, perfect.
I think that's better, actually.
Perfect. Yeah, thank you.
Okay, that's good. No, thank you. So the multi-channel video EEG is what we tend to use the most often, and it's the gold standard for monitoring neonates at increased risk of neonatal encephalopathy. And we tend to do this more often in our intensive care units, especially for high-risk neonates. And once we've identified a neurological problem, an acute neurological event, whatever it may be, then our electrophysiology department supports us with continuous EEG monitoring. So, so I want to focus a bit on continuous EEG and why continuous EEG. So longer measurement time is associated with higher detection rate for non-convulsive status epilepticus. And the rate is about 56% with 1 hour, but more than 80% with a 12-hour measurement. So I think this is what we want. We want better detection rate, and therefore a longer EEG gives that much more higher yield of abnormalities. Okay, and then when you combine this with other modalities like near-infrared spectroscopy, that gives you that furthermore advantage. So critical care continuous EEG refers to the simultaneous recording of EEG and clinical behavior, that is the video recording, over extended time periods, and that may be hours or days, in critically ill children who are at risk of secondary brain injury and neurological deterioration. So the goal here really is to identify changes in brain function such as non-convulsive seizures or ischemia, which may not be evident by neurological examination alone, and hence want to facilitate early identification and management. We know that these EEGs have to be, the data needs to be acquired continuously and reviewed intermittently for not only just technical quality, but also for changes in EEG patterns and for the interpretation and for clinical correlation. So EEG is useful not only for identifying seizures, but also for identifying background activity. The background EEG activity has a predictive value in outcome, and we know that seizures are a risk factor for later neurodevelopmental problems, death, and poor outcomes. And this is a snapshot I've taken from the Children's Hospital of Philadelphia critical care EEG monitoring pathway. You can see here that they have identified high risk factors for continuous EEG monitoring, and they've also provided the evidence. So this is really helpful. And so the indications for EEG monitoring continuously are HIE, cardiac arrest, non-fetal drowning or neonatal HIE, and if you're doing burst suppression management for intracranial hypertension or refractory status epilepticus, for ECMO patients, and for neonates following cardiac surgery with bypass. And you can see here that the hours they recommend is definitely more than 24 hours, and particularly for neonates, they want up to about 96 hours, and that is for the 72 hours of hypothermia, and then for the 24 hours when you're trying to 24 hours and more when you're trying to warm them up very gradually. For status and for intracranial hypertension, continuous EEG helps in medication management and dose titration. And for the less than 1 month of corrected age cardiac surgery neonates, it helps you to monitor them because by and large these children are sedated. So this is again a paper which is from the same group, and you can see here that clinically indicated continuous EEG, they did an average of 48 hours, and the EEG was read every 6 hours. You can see 18% of these neonates had EEG seizures, and 61% had EEG status epilepticus, and 15 of these had exclusively EEG-only seizures. And these EEG-only seizures were common in patients with low cardiac output state. And these were the ones who were more likely to die prior to discharge and have unfavorable outcomes than those without EEG seizures. So you can see that there's a real important merit in measuring or having continuous EEG. But it's expensive and it's resource limiting. And therefore, you can't have it for every neonate, but definitely for the high-risk neonate, it would be a very useful neuromonitoring modality. Now, again, this is another paper which looks at subclinical seizures, which are, again, after neonatal cardiac surgery. And you can see here that those children who had deep hypothermic cardiac circulatory arrest during cardiac surgery were the ones, and those who had delayed sternal closure, and that is those babies who have had open chest because of hemodynamic instability are the ones who are at higher risk for seizures. Now, all neonates with seizures, when they had brain MRI or ultrasound scan, they had diffuse or multifocal imaging lesions. So again, seizures can be a good marker for following these neonates up with further neuroimaging. Now, one question that we all would want to know is that can EEG identify early ischemia? And we know that it is exquisitely sensitive to impending cerebral ischemia, and that during ischemia, an EEG can show a progressive sequence of changes involving loss of fast wave activity. And continuous critical care EEG, particularly quantitative EEG, can be used to identify changes in cortical perfusion before irreversible infarct occurs. This is again a very nice paper, and you can see this is a more recent paper where it looks at EEG patterns preceding cardiac arrest, again in neonates following cardiac surgery. And you can see that this is a single center study where you can see that in the continuous EEG background, you can see low voltage. Then there is, first irreversible EEG change prior to the arrest and excessive discontinuity. And then, low voltage which is totally suppressed. And you can see then this patient is going into CPR. So again, these are predictable and helpful. So as I said, as intensive care doctors, we want to identify things before a catastrophic neurological event, and which may be like, for example, a cardiac arrest. So if these tools can help us, then that is far more valuable. So postoperative EEG seizures, why is it important to do for cardiac children is that we know that these children who had seizures in the immediate postoperative period are associated with worse neurodevelopmental outcomes, particularly impairment of executive function and a higher prevalence of deficits in social interactions and repetitive and restrictive behaviors in preschool children. And though they did not correlate with worse cognitive, motor, and language skills, they definitely were associated with impairments of executive function and higher prevalence of social, deficits in executive functioning. So again, if you look at the Boston circulatory arrest study, where they looked at children or neonates with transposition of great arteries after the switch procedure, they found that postoperative seizure occurrence was the medical variable most consistently related to worse neuropsychological outcomes at 16-year follow-up, including lower scores on reading, math, general memory index, executive function, and visual spatial testing. So EEG can be a predictive measure of neurodevelopmental outcomes in later life, and it facilitates opportunities for intervention and management strategies. Now, a little bit about Amplitude Integrated Eeg monitoring. This is the brain's machine, which we have used in our ICU. And this is again a seizures in a newborn supported on ECMO. And what I always say, this gives you the raw EEG and the Amplitude Integrated Eeg. And what I always say is that when a EEG, so this is the top panel is, the right, and the low panel is the left, and you can see here that it's markedly different. So it's showing you, laterality in neurological problems. And you can see here, and I always say this, when a raw EEG starts looking like an ECG, that's when you know that there is a problem. And here these spikes are representing seizure activity. And when you see this in the Amplitude Integrated EEG, you can see what I call like a church, steeple. So you can see these pointed things. And that suggests that this is seizure activity here. Whereas the overall background amplitude is probably okay, but you can see here how these church steeple effect is seen. So that suggests that there is seizures. Now, the American Clinical Neurophysiology Society's guideline on continuous EEG monitoring in neonates has given recommendations for EEG monitoring, and it says here that if there is perinatal HIE, infection, sepsis, any encephalopathy of metabolic or genetic origin, then you need to do EEG monitoring. And if seizures are suspected on EEG, the committee recommends conventional EEG monitoring if available, which should begin as soon as possible to confirm and refine the electrodiagnosis. And we know that EEG has been shown to reduce the total seizure burden, seizure duration in neonates, and the background assessment is important to provide early prognostic information in infants with HIE. And also it may be useful for risk stratification in clinical trials. I'm going to move on to a little bit of near-infrared spectroscopy. It is non-invasive. It's a continuous indirect method of monitoring cerebral blood flow. It uses near-infrared light, and it measures relative changes in cerebrovenous oxygen saturation by the sensors placed on the forehead. There are some difficulties with NIRS is that, that it is very dependent on the hemoglobin. It's also dependent on the tissue and the way the light scatters through it, and what we call as that it is very wavelength dependent. And what you need is the absolute path length, that is the the sensor and the difference between the sensor and the receptor. And I think these issues can be very difficult to deal with when we don't know how much the scatter is. So as you can see, that NIRS, it does not quantify oxygen molecules, but it calculates the ratio of light absorbencies and predefined wavelengths. And however, there are major issues. Can it be reproducible? Is, the variability, the calibration, and the validation of this. And then finally, does the cost exceed the benefit? Because we know that near infrared spectroscopy sensors are very expensive. Each sensor is about at least £100 here, and it would increase. And if you're doing two-site monitoring, then you need £200 per patient, and that may change if the sensor is not working. You have to put a new one every 24, 48 hours. Then the cost just adds up very, very quickly. So now this is a study which looked at near-infrared spectroscopy monitoring in preterm infants during the first days of life. And what they did was they had a control group and an intervention group, and they looked at cerebral oxygenation levels, which were visible, and the target was set to be at 55 to 85 in the first 72 hours of life. And in these two groups, they put them through a Bailey's test at 2 years and what you call the ASQ at 2 years. And what they found was that it was not associated with any improvement in long-term outcomes in these children. So reducing the cerebral hypoxia in the intervention group was not reflected in the MDI or the ASQ at 2 years of corrected age. And the number of infants with moderate to severe neurodevelopmental impairment was similar in the two intervention groups. And therefore, the SAFE Boost 2 trial was a feasibility trial that was powered to prove only the possibility of reducing the burden of cerebral hypoxia and hyperoxia, and it really did not show any difference. Now, we've looked at near-infrared spectroscopy use in pediatric cardiac ICUs in different parts of, within the UK and in Europe, and we found that not all centers were using it, though many of the intensive care consultants believed that it added value to the already existing monitoring variables, and they also felt that that it was essential. But when we asked them about protocols or guidelines for using NIRS, majority, 88%, had no protocol. Then we asked them, what are your targets? Where do you keep the near-infrared spectroscopy? In children with biventricular physiology, that is, the children who have biventricular, like ASD, VSD tetralogy, and univentricular would be the Norwoods and the hypoplastic left heart syndrome babies. And you can see nobody, 70% did not have targets, and here 55% did not have targets. And then when we asked, why are you not using it? A lot of people said that that was because of the not availability, the cost, the reliability of the data. So all in all, there are still many reasons why people do not use near-infrared spectroscopy. Now, does it matter? Does really, in the cardiac population, we saw that in the premature babies, it doesn't make a difference in neurodevelopmental outcomes. But what about the cardiac? And you can see here that neurodevelopmental performance was related to demographic and perioperative changes, particularly with reduced neurodevelopmental outcomes. And I'll show you this very nice figure here. And this is something known as the visual-motor integration test. So visual-motor integration test is a very key test, and it's I'm told, a very good marker for assessing neurodevelopmental outcomes in infants. And you can see that in those children who had, the low RSO2 or the low NIRS, the visual motor integration score was low, that is less than 85. And in those where it was better, the visual motor score was more than 85. So you can see that there is some correlation with monitoring with NIRS and later neurodevelopmental outcome. However, there are multiple studies here which show that there are, that it NIRS correlates with lower PDI on the Bailey, that, pre-op was affected, but not post-op in associated with worse neurodevelopmental outcomes. 48 hours is the key period for predicting adverse outcomes. A number less than 56% was predicting worse outcomes, and here this said less than 45% for low visual motor scores. So you can see there's a lot of impact of NIRS monitoring on outcomes. But then bilateral NIRS on the forehead at best will reflect what is going on in the frontal brain. But what you really need is a global picture, and that would be more representative. So let's look a little bit about cerebral hemodynamics. What are the determinants of cerebral blood flow? And you can see here that its oxygenation, flow, and pressure all are very closely related. And we know that the cerebral autoregulation depends on blood gas content, blood viscosity, body temperature, cardiac output, neurovascular coupling, and most importantly, cerebrovascular autoregulation. We know that from children who are supported on ECMO that they have a as they go on to ECMO, the cerebral perfusion pressure can fall and then it climbs up. So they're vulnerable, especially in that transition from just being connected to the ECMO circuit. And so that the first 12 to 24 hours can be very, very, very key for their outcomes. We also know that hypoxia in itself can disrupt cerebral autoregulation, leaving cerebral microcirculation vulnerable to alterations in systemic blood pressure. So we did some studies. Now, shouldn't the brain be able to protect itself? So we looked at the coherence between the oxygenated hemoglobin signal on near-infrared spectroscopy and the mean arterial blood pressure, and it gives you something that gives you an indicator non-invasively of cerebral autoregulation. And you can see here we did this, regional, that is, we had a child with 12 NIR sensors on, and you can see that it gives you a lot of information at different points, and you can see the blue marks suggest that there's increased deoxygenated hemoglobin, and you can see that the red suggests that that there is more of oxygenated hemoglobin. And what we are looking here really is what I call the concordance between mean arterial blood pressure and oxygenation. So basically, this may be a little bit complicated and not easy to explain everything in this one slide. But one very simple thing is that if the oxygenated hemoglobin signal on the NIRS correlates very closely with the mean arterial blood pressure, that means that there is regional impairment of cerebral autoregulation. The brain autoregulation should not be so actively dependent on the mean arterial blood pressure. So now we're having new application with NIRS, and that is using multi-channel NIRS and correlating that with the mean arterial blood pressure and coming up with this non-invasive cerebral autoregulation index. And this is something which you will see more and more of with time. And there are machines like this, which will give you multi-channel information, and they can be put on the head like a helmet, which will give much more global picture than regional picture. And you can see here that they're combining multimodal near-infrared spectroscopy and imaging. And what they're doing is really giving you an index, and what this is called an autoregulation index. And this autoregulation index correlates with neuroimaging. So neuroimaging score and autoregulation index. So now at this moment in time, cerebral autoregulation still is a very niche area. Again, very much a research tool, but there's nothing to suggest that in the next few years that this will become available at the bedside, where physicians and nurses will be able to say, oh, this is a situation where the cerebral autoregulation index is going abnormal, so we need to do something about it before you get into this situation like you have here, a scan with a bleed. So again, let's look at near-infrared spectroscopy and AEG, and you can see this is a nice picture of taken from the paper that I just showed you, where a term baby with HIE has got an abnormal AEG background. You can see here it's low, it's like less than 10, it's more closer to the 5. And you can see that there is very elevated RSCO2, that is very elevated to oximetry signal, which means that, that the metabolism in the brain is not right, and therefore the oxygen signal is very high, and it reflects like poor tissue uptake of the oxygen, and therefore that there is something not right here. And so now switching gears a little bit and going into ultrasound, CT, and MRI. So these are our neuroimaging. We always debate about this: what neuroimaging modality to use, when to do it, how often to do it. We know that ultrasound scan does not provide you with a resolution which is necessary for subtle structural alterations, and pre-op ultrasound scans and MRI always give you a much higher yield on the MRI, but ultrasound particularly has no association with later neurodevelopmental outcomes. So we know that it is the preferred mode to image the brain of an infant with an open fontanelle. It can be performed at the bedside. It's relatively safe, can be repeated when needed, and it enables evaluation of any evolution of the lesions. I mean, it's easy to see when things are getting worse. However, there are major limitations. The imaging quality depends on the skill of the operator. Some areas of the brain are difficult to visualize, particularly cerebellum. You may be able to see with a transmastoid view, and you have to remember that it has good sensitivity for detecting extraaxial lesions, but intraparenchymal and intraparenchymal hemorrhage. But for cerebral ischemia and deep down intraparenchymal hemorrhage, the sensitivity is limited. I'm going to talk a little bit about the optic nerve sheath diameter, and I said to you a little bit earlier, this is something which we are doing now more often to look at, is there cerebral edema, is there pressure? And we know that you look at this here, this is the optic nerve sheath diameter, and there are, this nice paper which shows you the measurement of optic nerve sheath diameter, and what they're saying is the upper limit of normal for optic nerve sheath diameter is 4.5 millimeters in patients over 1 year of age, and 4 millimeters in children less than 1 year of age. And actually, it's also very easy to see pupillary reactions. So in children who have got very, swollen and edematous lids where you can't open well enough to see pupillary reaction, you can hold your probe like this, shine the light, and you can see the constriction of the pupil right at the top here. So this is a newer way, and bedside, non-invasive, and a skill that can be taught easily and can be reproduced easily and often. Now, cranial ultrasound scan, you can see this is a picture of a recent, I pulled out from one of our ICU patients, and you can see that there is increased echogenicity on the right side. This poor child was very, very sick on ECMO, and you can see that there was an infarct, which is picked up on the brain, CT brain, the right middle cerebral artery infarct, and you can see the MRI further confirmed it. But whilst we know that if there is an abnormal, acute neurological event, then yes, doing all these tests is easy. But we have to remember that taking these children to the CT scanner is a tricky. It needs a lot of staff, as you can see here. And should we be doing routine routine scans? Because we know that intra-hospital transfer is not without its own risks. We don't do routine scans for even children who are supported on ECMO, but in the adult world, it is very common to do routine CT scanning, and you can see that in 17% of this paper that they identified abnormalities, and then that helps them to moderate and modify their anticoagulation strategy for patients on ECMO. But would you consider doing a routine MRI in the absence of risk factor? How relevant are MRI abnormalities if there's no obvious acute clinical or neurological signs? And don't forget that everything comes with a cost, availability, the need for anesthesia, is very, very important. So the driver at the end of the day for requesting MRI brain will be clinical. Now, MRI brain in the post-ECMO group, we are tending to do these more often, and that is to identify clinically unrecognized brain injury. We have been hearing a lot about silent brain injury in neonates, and it also helps us categorize patients at higher risk of adverse neurological outcomes who may need closer neurological follow-up. So it's really key. We're doing it more and more in our ECMO survivors. Again, there are a lot of advances in MRI technology. It enables us to identify high frequency immature brain development injury. It gives a better visualization of the brain and can help assess metabolic integrity of the neurons in specific brain areas. And we know that both brain immaturity pre-op and newly acquired white matter injuries are very common after major cardiac surgery. And more importantly, we're hearing more and more of the hippocampus, reduced hippocampal volumes in adolescents who have undergone surgery, and that you can only pick up on an MRI. I'm coming to the end of my talk, and I'm just going to go a little bit now on, what's the purpose? At the end of the day, why should we be doing neuromonitoring and neuroimaging? Can it help us do neuroprotection, and can it help with outcomes? So, can neuromonitoring and neuroimaging help with neuroprotection? There are no universally agreed intervention algorithms. Global measurement with the refinement of signal to indicate impaired cerebral autoregulation may give us a safe range. EEG, we know that continuous EEG improves seizure detection and can identify ischemia. We know that EEG alone cannot predict neurological outcome, and MRI helps in identifying lesions, severity, and prognostication in the event of a clinical indication. Now, can neuromonitoring and neuroimaging help predict outcome? Again, as I said, there is no protocol, thresholds vary, and targets vary with years. EEG alone cannot predict the neuro outcome. However, serial EEG may improve the predictive value for neurocognitive deficits. Cranial ultrasound scan is sensitive but not specific for structural neuroinjury. And if you have a normal head ultrasound scan and a normal EEG, then it may predict normal CT or an MRI scan. However, you can get abnormalities which may be identified in later CT or MRI, which are not seen on earlier head ultrasound scans. We know that there is evidence of non-hemorrhagic brain injury that has far more worse neurodevelopmental outcomes than just isolated hemorrhagic brain injury. So what we really need is neuromonitoring and to go hand in hand with neuroprotection and neurodevelopmental follow-up. So, the dictum is do neuromonitoring often, be extra vigilant, identify risk factors, and then do protocol-driven monitoring. Neuroprotective strategy, avoid sudden shifts. So whatever it may be, hyperoxia, hypoxia, hypercarbia, just be very, very careful and avoid hypothermia at all costs. And every patient should have follow-up, which should be family education, and should not only have primary but also secondary care understanding. So what's the recommendations for neuromonitoring? It is regular frequent neurological examinations, continued vigilance, cranial ultrasound scans that can be done at the bedside and repeated depending on clinical indication, often EEG, particularly when there's a high risk and depending on clinical indication, continuous EEG wherever feasible as the yield is higher, low threshold for CT if any abnormality on ultrasound, EEG or clinical concerns. NEARS, look at the trend, use it in high-risk patients in post-op cardiac on ECMO or weaning off ECMO, and use MRI brain to prognosticate follow-up. So we know that, especially in ECMO children, that 8 years, 17 years later, that these children can have verbal, visuospatial working memory problems, and parents report aspects of executive functioning as impaired. So there can be late and long-lasting effects on neonatal ECMO survivors. And we also know that memory plays a very, very important part in educational attainments, academic achievements. And this is our own paper where these children were having no overt neurological abnormalities. But you can see between 8 to 16 years of age, we found that their memory was impaired. And on MRI, the hippocampal volumes were much, much more smaller than normal. So there is what I believe a common neurodevelopmental pathway for memory deficits following neonatal critical illness, and this is the vulnerability of the hippocampus. This vulnerability of the hippocampus can be related to either in preterm birth, congenital heart disease, neonatal ECMO, congenital diaphragmatic hernia. And further insults are hypoxemia, ischemia, inflammation, glucocorticoid concentration, anesthesia that we give our children. And all in all can affect memory, can cause hippocampal alterations and cause memory deficits, which can lead to learning problems. So in summary, neuromonitoring is a useful and important adjunct to be interpreted in conjunction with all available hemodynamic data. Trend is more important than absolute values. You cannot substitute neuromonitoring for hemodynamic monitoring. Additional monitoring brings an expense, adding complexity to patient management. That's where protocols are important. Multimodality monitoring is important. Just don't go by one particular modality. We need research to inform guidelines and develop consensus, and that's challenging. Neuromonitoring alone is not enough. You need neurointerventions and neuroprotections. Assessment should continue beyond intensive care unit, and multidisciplinary follow-up is extremely valuable to the overall health of ICU graduates. So with this, I thank you all for listening to me. I acknowledge the patients' families, colleagues and staff at Great Ormond Street Hospital, and thank you. If you have any questions, you can always email me or this Twitter link. So with this, I'd like to stop this presentation and we can take some questions. Thank you very much.
Thank you very much, Dr. Aparna, for this excellent session on neuromonitoring and also emphasizing the importance of neuroprotection and neurodevelopmental follow-up. And I couldn't agree more. I guess I can start off the questions with one of my questions. Actually, I was just wondering, as you went through your lovely talk and talked about the various modalities for neuromonitoring, I just wondered what you would do with a typical patient of yours on ECMO. How you would monitor them, and also what would you do? What are you currently doing for their follow-up for a typical patient?
So we have all the neonates by and large will have had an ultrasound scan before going on to ECMO. After they're on ECMO, then we repeat scans and we do it often, depending on the clinical condition. We don't say we do it daily. We say we do it at least twice weekly, and sometimes thrice weekly, depending on the clinical condition. If there's a high risk factor, then more scans are done. If there are not so high risk factors and we can observe the child clinically, we don't do as many ultrasound scans. The CT is only done when there is a acute neurological event, what I call A&E, acute neurological event, and that could be some abnormal movement, a seizure, or an ultrasound scan that has picked up some abnormality. Then that's when we would do a CT scan. All our ECMO patients get NIRS monitoring throughout their ECMO course, particularly in the first 3 days. And particularly when they're coming off ECMO, I think that's the time, or if we're doing any manipulations to their circuit, that's when we do NIRS monitoring. And then finally, we recommend MRI for all our ECMO graduates. All ECMO graduates would get MRI. The optic nerve sheath thing we have started lately doing it, especially when we have very swollen children. And especially on ECMO, if you have a baby who's been resuscitated and comes to you and goes on ECMO, then has third spacing, and there's generalized anasarca, you can't open the eyelids to see. That's when this is very useful.
Great, thank you very much. Just about your neurodevelopmental follow-up, how long do you follow them up for, your ECMO patients?
So our current strategy is that we have we give a call to the families at 3 months, and we speak to them and check how the child is doing. And then we recommend that the pediatrician, local pediatrician, assesses the child. And if there are any clinical concerns with regard to neurodevelopment, then they get referred to the neurodevelopmental service. We then again have another call at 6 months. And then finally, we call them at 1 year back to us for a follow-up. Beyond that time, because we just don't have the resources, and it is not ideal for these families to keep coming back to the ECMO center, we say that the 1 year follow-up clinic is the signpost, and if there are abnormalities picked up at that time, then the children are then routed into the local community services for providing that follow-up.
Great, thank you very much. I've got a number of questions coming through. So the first question is from Dr. Javed, who asks, any role of doing optic nerve sheet diameter before LP in neonates, before a lumbar puncture in neonates?
There's not that much information about it yet, because it's something we have used it as a marker for assessment. We've not used it as a marker for this particular way of doing an intervention. It's more as a marker for assessing if there's a concern, and if there's a concern, then we activate the next step. That is, it's used more as a monitoring tool rather than as an intervention tool. But if you look up that same paper that I put up, which talked about the sizes and how big the optic nerve sheet diameter should be, they were all done in children with hydrocephalus. So that was the reference frame. So there is more and more literature coming out on that. But at the moment, we use it mainly as an assessment. It's just more as an assessment tool to see, because it's a big thing for us when we're not able to see the pupils in children who are critically ill. And I think this is just one way of working through it.
Great, thank you. The next question is from Mr. Ibrahim, who asks, who reads the EEG? Is it the neurophysiologist or intensivist? I guess that's an interesting question, because not all of us are trained in reading EEGs, and there's resource limitations. Not everyone has access to a neurophysiologist.
So where you have continuous EEG, by and large, we need electrophysiologists, neurophysiologists to report on that. It is beyond the remit, ICU training to be proficient in looking at continuous EEG. I think with Amplitude Integrated Eeg, yes, you can train neonatologists to look at it. But I think as far as it goes with continuous EEG, it is the interpretation is by neurophysiologists. So in our hospital, it would be the neurophysiologists, and they have remote access. And we as intensive care consultants, if we worry that the child's clinical condition has changed, we will call them and say, can you look at the EEG?
Yeah. I think that's really quite important, because you would probably always have someone on call who's looking at the EEG remotely and be able to tell you immediately what they thought about it at the time. So, I mean, I guess, again, that goes back to having the resource to have a neurophysiologist who is available and willing to do that. Okay, the next one is from Dr. Mohammed Ashraf, and he says, great presentation. What are the basic minimum modalities that would optimize neuroprotection in low resource settings, and how to go about it?
Very good question. Sadly, I think, it's a very, very tricky one. I mean, for me, I think an ultrasound scan is probably a very good investment. And, if you can train the neonatologists to do good ultrasound scans, then I think it's something that is very helpful. I think using, things like the optic nerve sheath diameter, again, it's a very easy to train intensive care doctors, the big word is focus these days. It's a form of focus, and you could use that at bedside. So that would be really useful. For me, I think the next after that is EEG, but then continuous EEG is very expensive and resource limit, it needs lots of resources. But I think a bedside ultrasound scan, EEG when possible, and then using modalities like CT and MRI when there is an acute neurological event, I think is probably the easiest. But never ever forget that really what you need to do is good bedside neurological assessment, and there can't be anything more important than that. And we've seen this many times that, our children are sedated, you reduce or muscle relax, you lift the muscle relax, and then, then a neurological problem becomes apparent. So therefore, my recommendation first and foremost is try to use as less sedation as you need and avoid muscle relaxation on everywhere, anytime, unless you have to, don't use muscle relaxation continuously. So that would be my one simple message is, nothing can beat clinical bedside monitoring of a patient.
Great, thank you. Our next question is from Ganji Shivalingam. I can see there's a lot of interest in the optic nerve sheath measurement. So the question is, does optic nerve measurements help in predicting cerebral edema? And also, what is the ideal time period to do MRI after a child has suffered hypoxia to predict neurological outcome?
Okay, that's so I don't think there is data in optic nerve sheath diameter neurodevelopmental outcome. That at this moment it isn't. It is at the moment just it's like a screening, just like how you use AEEG. If you see an abnormality in AEEG, you have to do a full EEG. And the same way, if you have an abnormality in optic nerve sheath diameter, then it is a signal that you need to assess this neurology more. And whether you need to do clinical examination, whether you need to do ultrasound scans, whether you need to do CT or MRI, I think it will help you in that direction. The question about when to do MRI after brain injury is a very important question. I think, you will notice that there is this thing a term which many people use called pseudo-normalization. So either you do it very soon after an injury, that is in the first 4 days, or you do it anywhere between 8 to 12, after 8 to 12 days. And I think that's because in the intervening period, there is something called the pseudo-normalization. So your signal may not pick up any abnormalities. So either you do it early MRI immediately after, or you do it at about in the second week after injury. That gives the best prognostic marker for later neurodevelopmental outcome, what interventions you need, how you need to counsel that family.
Thank you. We have, there's another question from Dr. Javed. He says, does optic nerve sheath diameter measurement have any value in treatment of raised ICP in neonates?
I think there is some, and that's where I think the entire study on how to measure that has come from this hydrocephalus monitoring and raised intracranial pressure. But I must confess, I use it more as a neuromonitoring tool. I don't use it for intervention.
Thank you. We have Dr. Abhishek Paul. He's asking, he says, just deviating from the topic, but what is your opinion on the recent Lancet paper on use of therapeutic hypothermia in HIE in low and middle income countries. The Helix trial, which says that therapeutic hypothermia is not effective, what should be the treatment then? I think that is a $1 million question, really. Slightly difficult to answer, I would say. And I think the article itself alludes to a couple of interventions that might be more beneficial in lower and in lower middle income countries. But I think, it's something that we all want to know. I don't know if
yeah, that question probably desires a whole panel discussion as a separate session. But we would like to know your one quick opinion on the paper, Dr. Aparna, if you come across.
So my feeling, I mean, I'll tell you what I think about hypothermia. I think it's a very valuable tool, but unfortunately, it doesn't produce the desired results. And we know that I'll just tell you something about in the UK, if there is a neonate who qualifies for systemic hypothermia, especially HIE, I'm talking about HIE neonate who qualifies on the basis of the TOBY trial to be cooled. These babies have to be moved to a center that does the cooling, offers them continuous EEG monitoring, has the potential to do brain MRI scans or CT and brain MRI scans. And there's a whole system that needs to be put in place to manage these children. So my feeling is that just on practical terms, I think that for the resource limited environment, this is going to be really tricky. So I would say that just as from practical personal experience of these babies who get moved around, I think that just wouldn't work. And whether there is that benefit of moving a baby just to provide that, but I still never really understand that very well. Sadly, hypothermia has not bailed out as an important intervention, neither in cardiac arrest, neither in asphyxia, neither on ECMO. It has just not helped. And from the out of hospital cardiac arrest and in hospital cardiac arrest as well, it hasn't shown. So now, also another thing I wanted to say is that I remember, I don't know whether you all know about this NEST study. So many years ago, we did this NEST study. NEST study stands for Neonatal ECMO Study of Temperature, so NEST. And here, what we did was we cooled babies who had hypoxemic respiratory failure on ECMO. So if you want to effectively cool a baby, the best thing is to cool whole body through a extracorporeal circuit. Nothing could be better than bringing the body temperature down than an extracorporeal circuit. Yet, in these babies who were cooled for 72 hours, there was no benefit at the 2-year mark by babies. So what I feel is that sadly, the hypothermia, therapeutic hypothermia, has just not delivered on that, on that front. It's just not delivered what the neuroprotection and the neuro improvement we want in the outcomes. It's just not lived up to that expectation, sadly. So that's my view. But what I truly believe is that hyperthermia is bad. The rate of rise of temperature is bad. And if the systemic hypothermia can do one good thing, and that is you do not let the body temperature go up, then you have mitigated the risks from the body temperature going up. You've offered these babies a very close temperature monitoring. So because of that temperature monitoring, you're seeing that their pressure, their temperature doesn't go up. And I think that alone in itself is important, is what I feel. I hope that answers the question.
Perfect. Yes, I think that's pretty much actually in the nutshell. I think anyway, we'll not extend the discussion on that topic, but I think if it's to be done, it has to be done in a proper way. Otherwise, it could be more detrimental or harmful. And that's where I think the discussion lies. And also, I think the kind of population in LMIC regions is a bit different. The hypoxia tend to be more chronic. It could be even intrauterine malnutrition and hypoxia. So this, and lot of these babies are outborn. So by the time they reach the tertiary center, there's already worsening of the hypoxia. There's a delay in commencing. So a lot of factors are there. So I think, yeah, that is a separate topic of discussion. It was very alarming study and raised a lot of discussion. So we'll continue.
Yes, yes,
Maybe
I
we'll
can
have
imagine.
we'll have a session definitely on that. So I think there are no more questions. Then Dr. Rupali, we can stop the session. So
I think it's been a fantastic session, really, and
Mhm.
thank you so much, Dr. Aparna. It's always a pleasure to get in touch with you and to meet you. Hopefully once the pandemic situation resolves, we start meeting each other and actually listening to you in person. That would be fantastic.
Yes,
Thank
absolutely. Yeah.
you. It's my
So
pleasure.
perfect. And thank you for honoring our invitation and doing this session. So it was an
My
excellent
pleasure.
session. Thank you. And thank you, Dr. Rupali, also for conducting and moderating this session.
Thank you.
And thank you everyone who has joined. I think a lot of people stayed till end. We had a good turnaround and good interaction. So thanks a lot. And we'll see you again next month with another session. So thank you, Dr. Aparna and Dr. Rupali.
Bye-bye. Bye-bye, everyone.
Bye.
Thank you.
Bye.
See you next time.
Thank
Bye-bye.
you. Lovely to see you, Rupali and Kiran. Thanks a lot. Huh? Thank you.
See you. Bye-bye.
Bye.